would like to welcome all in this last session of PG free paper of glaucoma and mixed bag. First of all, I would like to call the chairperson of this session, Dr. Amarnath Chaudhary sir, Dr. Vibhuti Prasad Sinha sir, Dr. Pooja Sinha ma'am, Dr. Sajji Sinha ma'am, Dr. Sajji Sinha sir, and Dr. Ranjana ma'am, Dr. Ashok Jha sir, the panelists of this session, Dr. Bandana, Dr. Tarunum ma'am, Dr. Abhishek Kedia, Dr. R.P. Thakur, and Dr. Sitesh. And convener of this session, Dr. Manoj Kumar Singh. Co-convener of this session, Dr. Nilesh Kumar.
सिम्हा सर को बुला लीजिए.
Sir, Simba sir. And Ashok sir, please come sir. Okay. Judges को announce करने क्या? Okay. Okay, now I am going to start the session. I would like to call Dr. Priyanka Mohanty from PG AIMS Patna.
Shall I start, sir?
Okay, start.
Good afternoon, everyone. I am going to present a case report on bleb needling after trabeculectomy in a patient of JOG. There is no financial disclosure or no conflict of interest associated. Juvenile onset open-angle glaucoma is a subset of primary open-angle glaucoma diagnosed before the age of 40 years, and it has prevalence of around 3.8% of all POAG. The risk factors include myosin gene mutation, myopia, male gender, and African race, and the management options include medical management and surgical, of which mainstay is trabeculectomy. But as you know, trabeculectomy blebs can fail and they are prone for scarring, and various augmentation options include topical eye drop, surgical revision, or bleb needling with or without use of antifibrotics. And the approaches include ab externo approach or ab interno approach. Needling is a less cumbersome procedure which cuts through the fibrous tissue to enhance the fistula, and it is equally or more effective than revision surgery. Ours was a case of 16-year-old male child with diminution of vision of both eye for 6 months, which was gradual in onset and progressive in nature, and occasional watering was there, but no pain, redness, or floaters. There was no history of ocular trauma. He had underwent both eye trabeculectomy in 2018 and was lost to follow-up thereafter. He also had poor compliance on eye drop brinzolamide, timolol, and bimatoprost. He also had prescription glasses use for 6 years. There was no family history of glaucoma diagnosed, and general and systemic examination was within normal limits. At presentation, his uncorrected visual acuity was finger counting at 1 meter with PR accurate, which improved up to 3/60 in right eye, and in left eye it was 6/60, improving up to 6/6. IOP on GAT was 30 and 24 mmHg respectively, and rest was within normal limits. On examination, diffuse bleb was noted superiorly in right eye with IBAX grading system H1E2 V2 S0, and in left eye it was H2E2 V2 S0. Cornea and AC was not significant findings. And on iris, surgical PI was noted in both the eyes at 12 o'clock. On fundus examination, the disc was of normal size with cup disc ratio 0.8:1, FR plus, and pale NRR with nasalization of vessel was present, and inferior notching was prominent in the right eye. He also underwent He underwent gonioscopic evaluation with ciliary body band and prominent iris processes, but as you can see here, also on temporal quadrant of right eye, goniosynechy was present and PI was patent in both the eye. On further investigation, CCT was done with right eye CCT measured up to 550 micron and left eye 538. On OCT RNFL, it was outside normal limit in all the quadrants barring the nasal area in right eye, and in left eye, it was all outside normal limits. On HFA 10-2, only left eye was done as right eye had poor fixation and only one quadrant vision was preserved. On ASOCT, diffuse bleb with no microcyst and uniform reflectivity was noted, and bleb thickness was 66 micron in right eye and in left eye it was 110. He underwent after right eye ab interno needling of the bleb. As you can see here, intraop gonioscopy was performed and Grover-Spellman sclerotomy spatula used to cut through the fibrous tissue with multiple approaches, and then intraop bleeding was noted, which is actually a good sign. After that, his right eye vision was improved up to 2/60 and also pressure was controlled up to 14 mmHg and bleb was formed, which is of grading H2E to V2S0, and bleb thickness also increased. Patient was continued on topical eye drop. So coming to the discussion part, bleb needling in failing trabeculectomy can be done if the osteum is patent, and it can be done either as a slit lamp procedure or an operation theatre. Ab externo approach gives us direct access and is more effective if there is significant scarring present, but ab interno approach is minimally invasive and it has less risk of bleb leaks. As an adjunct, mitomycin C can be used, which is proved to be more effective than 5-fluorouracil. Also, we can go for ASOCT, which provides us detailed morphological feature to compare before and after, rather than slit lamp. And it has been seen that multiple refractivity with multiple internal layers have higher success rate. These are few of the related studies done, like our similar study with the use of 5-fluorouracil, mitomycin C, and ab interno approaches. And I would like to conclude saying that JOAG poses a higher long-term disability as it is earlier in onset, hence early detection, timely treatment and lifelong monitoring is essential, and family members and myopes should be regularly evaluated, and timely recognition of a failing bleb should be done to, as needling provides as an inexpensive, safe and simple intervention and is a viable alternative for resurgery. Also, ab interno approach gives us a direct access and minimally invasive and effective method for the same. Thank you.
As it is a competitive session, that's why only judges can ask the question. Judges, please.
Well presented, Dr. Priyanka.
Thank you.
And well documented, I will say. And you have done this case for which type? Early bleb needling or late bleb needling?
Late, sir. After it was done in trabeculectomy was done in 2018, and patient was lost to follow-up for some time, and it was done in 2024, like recently.
Okay. And in gonioscopy, what in video we are saying you have whatever the procedure you have done.
Ab interno, sir.
Ab interno. So it was done only for ostium release.
No, sir. Osteum was patent. We are using ab interno approach rather than ab externo approach to release the fibrous tissue, sir. Osteum was patent. Also, no iris was occluding, but we are going for ab interno rather than ab externo.
Okay.
Thanks.
So, Priyanka, so you did raise the flap ab interno.
Yes, sir.
You did raise the subscleral flap ab interno.
Through the spatula, yes, sir.
So it was easy to raise.
No.
Did you find any resistance there?
In this case, there was no resistance, sir. The iris was not occluding.
Okay.
Now I would like to call Dr. Ajaz Alam.
Good evening, sir. Myself, Dr. Ajaz, second year junior resident from Anugrah Narayan Magad Medical College, Gaya. My topic is corneal hysteresis as a biomarker in glaucoma current inside. Glaucoma is a progressive optic nerve neuropathy characterized by loss of retinal ganglion cells and their axons, causing irreversible vision loss. IOP is the most significant risk factor, only parameter for which treatment has proven to decrease the risk, incidence, and progression of glaucoma. Diagnosis and management mainly based on family history, optic nerve head evaluation, intraocular pressure, visual field testing, OCT, and central corneal thickness. How glaucoma develop? Resistance at the level of conventional outflow pathway, perfusion pressure to the optic nerve head, and translamina cribrosa pressure. In one study, it is estimated that 30 to 50% of glaucoma patients have normal IOP, suggesting that there are other risk factors that need to be considered in the management. In normal tension glaucoma study, despite 30% decrease in IOP, not halt the progression rate of glaucoma. The early manifest glaucoma trial shows for more than 45% of treated patients had glaucomatous progression after average decrease of 25% in IOP. Corneal biomechanics provide insight on how the cornea behaves in certain situations and can reflect the vulnerability of the optic nerve head and optic nerve head to glaucoma. Corneal tissue is a complex viscoelastic structure, meaning that it demonstrates elements of both viscosity and elasticity. Corneal hysteresis is a measure of the viscoelastic damping of the cornea, which reflects the ability of the cornea to absorb and dissipate energy. Corneal hysteresis can be understood by viscoelastic system of the cornea that can compare to an automotive suspension, where the elastic component is the coil spring and the viscosity is the shock absorber. This is the instrument which measures the corneal hysteresis. In ocular response analyzer, when the jet pressure P1 is given, the cornea undergoes inward applanation, and P2 is the pressure at which the cornea bends back to normal configuration. The difference between the two peaks is corneal hysteresis, defined by the P1 minus P2. Normal level of corneal hysteresis. Sa et al. Says average corneal hysteresis 10.7 Hg, and Carbonaro et al. Says average corneal hysteresis of 10.2 mmHg. Low corneal hysteresis is associated with visual field worsening. The anatomical connection. In an individual eye, the cornea, sclera, peripapillary ring, and lamina cribrosa are all made from extracellular matrix coded by the same gene that creates collagen formation. Therefore, an eye with a more deformed cornea could potentially have a lamina cribrosa that is less able to dampen pressure changes and suffer glaucomatous damage from an elevated IOP. Corneal hysteresis correlated with IOP lowering interventions and age. No correlation with corneal radius, astigmatism, spherical equivalent axial length, or IOP. Corneal hysteresis and mechanical reduction of IOP. Agarwal et al. Says glaucoma patient with lower initial corneal hysteresis experience significantly greater reduction in IOP with primary prostaglandin agonist therapy. Bolivier et al. Says glaucomatous eye with low baseline corneal hysteresis were associated with a greater therapeutic reduction in IOP. Corneal hysteresis with age. A general reduction in mechanical compliance has been demonstrated in the cornea, lamina cribrosa, and sclera. The stroma makes up about 80% of the corneal structure and is mostly composed of type 1 collagen fibrils. As ocular tissue ages, collagen fibrils diameter increases within the stroma as well as increase intermolecular spacing of the fibrils, which may be a possible explanation as to why corneal hysteresis decreases with age. Corneal hysteresis and central corneal thickness relationship. Ocular hypertension treatment study shows non-linear correlation between the corneal hysteresis and central corneal thickness. We can see the video in cases of high corneal hysteresis. Sorry. In cases of high corneal hysteresis, less amount of jerk produced in case of good suspension car like high corneal hysteresis. In cases of low corneal hysteresis, we can see how more amount of jerk produces. Take-home message. As stated, corneal hysteresis has been associated with progressive visual field worsening, the presence and severity of glaucoma, the conversion of glaucoma, and the rate of progressive visual field worsening. There is enough data to support why corneal hysteresis as a parameter to be considered in the management of glaucoma patient and warrants consideration in making treatment decision. Thank you for patient listening.
Interesting presentation, judges. Is there any question or comment, please?
So with these many informations which you have on corneal hysteresis, how do you apply that on a patient who is coming to you in clinic?
Yes.
Suppose one patient comes to you in clinic,
Yes, sir.
he has glaucoma.
Yes.
How do you apply these knowledge which you have just said wonderful? How do you apply this on your clinical patient?
Sir, corneal hysteresis measurement instruments is not available in our center, sir. So only
Suppose you have it. Suppose I give you an ORA. It is there in your institute. How do you apply that?
Sir, corneal hysteresis increases with age. So, sir, we can see her age and many other things like RP and RNFL.
Actually, it's a really very burning issue in glaucoma
Yes, sir.
and well connected. So I think this part regarding this, how it is applied in clinical practice, that should be focused.
Yes.
That's one suggestion. And another part, you have beautifully demonstrated what corneal hysteresis is. Thank you.
Thank you, sir.
Okay, now I would like to call Dr. Swati Singh, JR from ANMCH.
Good evening, everyone. This is Dr. Swati Singh, GR from NMMC Gaya. I'm here to present a talk upon current trends and insight into nanotechnology and management of glaucoma. I have nil conflicts of interest and financial disclosure. As we know, glaucoma is a leading cause of irreversible blindness, and it is estimated by the year 2040, there will be 111.8 million people who will be affected with glaucoma. Let's get into the history of medical treatments in glaucoma. Dated back to 400 BC, Hippocrates and Sushruta used herbal mixture and compresses to treat glaucoma. 1978 only beta blockers made their entry. Then came the prostaglandins, latanoprost being the first one. Later on, it was followed by travoprost and tafloprost being the latest one. As we all know, the management primarily depends upon the IOP. IOP still remains the only modifiable factor in treatment, but we all know that there's a delay in progression, but no recovery. So the current drugs in use that we have are the prostaglandin analogs, tafloprost and travoprost being the latest one. Beta blockers, timolol being the most common drug of choice, carbonic anhydrase inhibitors, topical and systemic ones, adrenergic agonists, and parasympathomimetics. So why do we need alternative drug treatments is the question of choice. Because we want to improve the quality of life, health related of course for the patient, we need drugs which provide longer half-life, higher efficacy, lesser side effects, look for neuroprotection, then the drugs which are preservative-free and economical. Pre-existing allergies and unwilling for surgery, those kind of patients also require other alternative drug treatments. The novel drugs that are into play are Rho kinase inhibitors, goes by the name nitazoxanide, nitric oxide donating prostaglandin analogs like latanoprost bunod, 0.024%, then fixed drug combination Rho kinase inhibitor and latanoprost. The targets that other than IOP that can be thought about are that is because despite reduction in IOP, what we see is that glaucomatous damage keeps occurring in at least 50% of the patients. So hence we need to explore other options as well. So those could be like neuroprotection, working on neuroprotection, for example, brimonidine by vasomodulation, apoptosis downregulation, stem cell therapy involving mesenchymal stem cells and human embryonic stem cells, neurotrophins, ciliary neurotrophic factor, recombinant human nerve growth factor, all these can be used. Gene therapy, which can target myocilin gene and also tunica interna endothelial cell kinase and targeting apoptosis. Other drugs, memantine, citicoline, cannabinoids, latrincolin derivatives, antioxidants like ginkgo biloba extract, calcium channel blockers. All these aside, what are the limitations of current glaucoma treatment is what we need to see. So there's low compliance of medical treatment as there's ocular discomfort and frequent administration cycle. Then there's low bioavailability of the medicine as only less than 10% of the drug absorbed into the eye. Only 1% of that reaches the aqueous humor, either via the transcorneal route or the transscleral conjunctival route. Surgical treatment failure due to fibrosis of surgical site, irreversibility of glaucoma-induced vision loss, retinal ganglion cell death is not reversible under current treatment. So let me introduce to this beautiful field of nanomedicine now. That is what I actually want to talk about. Richard Feynman is known as the father of nanotechnology. Science, engineering, and technology conducted at the nanoscale, which is about 1 to 100 nanometer. That is how you use nanotechnology, all these fields combined, and there are materials of different sizes, different shapes that can be formed. Hence, what happens is basically the particle size gets smaller and surface to volume proportion of the particle becomes larger. You can modulate the physical and biochemical properties of the particles, which can cause electrical conductivity, biocompatibility, magnetic properties, biodegradability. Nano delivery systems, those are nanoparticles, nanosuspensions, liposomes, cyclodextrins, nanodiamonds, dendrimers. All of this picture shows the superiority of nanoparticles in relation to conventional drugs in future, of course. So as a novel drug delivery system, you can encapsulate or conjugate these drugs like DNA, RNA, antibodies, all of that with the nanoparticles, and then give it intravitreal or intravenous, and it reaches the particular target site, which leads to increased residence time and also a very targeted delivery. Let me emphasize. It provides more targeted delivery, there's sustained release, bioavailability improved, dose accuracy improved, minimal tissue irritation, longer shelf life, and better solubility, of course. Ophthalmic devices using nanotechnology is basically contact lens using solvent impregnation method. You can use both hydrophilic, hydrophobic drugs, and then you can give the drugs. And there could be a more targeted delivery and as well as efficient drug dosage. Loading could be there. Ocular inserts into conjunctival cul-de-sac functional drainage devices. TM regeneration and neuroprotection using mesenchymal stem cells can be done. Hence neuroprotection again. Advantages being the prolonged half-life of the drug, then tunable size, physical chemical properties modified, and higher bioavailability, of course. But the disadvantages being inefficient drug loading, inefficient drug loading, physical instability, possible toxicity, and also clinical translation. So my take-home message would be, glaucoma is significant global health concern. Neuroprotection and other non-IOP targets have to be explored. Nanotechnology can revolutionize drug delivery, enhance therapeutic outcomes, and improve patients' quality of life. Ongoing research in nanotechnology is required, which can contribute more effectively and can cause targeted glaucoma therapies in the future. Thank you so much. I hope this presentation piqued interest in nanotechnology and we come up with more and more exploration into this field. Thank you.
Nice presentation. Judges, comment please.
So nice summary, I will say, regarding nanotechnology in glaucoma management, Dr. Swati Singh.
Thank you, sir.
And can you name few drugs which are in evolution and it's about to come in another 2 to 3, 5 to 5 years, basically? There are few drugs. Name anyone.
Few drugs as in which can be used as nanotechnology, nanoparticles.
Yes,
Timolol, Acuvu by the silicon embedded contact lens. It is in play. Then there is also, apart from that, betaxolol lead-in contact lenses.
Okay. And definitely this technology will be useful, and there are, in your era, after 10 years, there are many drugs which will come in a nano form.
Yes, so in cancer therapy, it's already being explored.
Wonderful presentation, Swati.
Thank you, sir.
Basically, drug remains same. The delivery systems actually is enhancing and technology is giving way so as to increase the bioavailability, right?
Increase the bioavailability as well as possible dosage loading. Like, so sometimes what happens is like, basically, you use 20% of the drug is only loaded. Yes, sir.
Pause. So your presentation was on nanotechnology.
Yes, sir.
That was 6 minutes. You spent your 3.5 minutes on conventional method. Whatever you present is very good. What I am telling you for your future advice is,
yes, sir.
stick to the presentation topic more.
Okay.
The periphery and all should be 1 minute, introduction and all.
Okay.
Stick more onto the topic itself. Your 3.5 minute is on to the conventional glaucoma topic.
Okay. Current trends also, I mentioned about certain drugs that could be explored, neuroprotection.
But that was not your topic.
So
Your
current
topic,
trends and insight into nanotechnology. I understand, sir.
and you did not mention about cost.
Yeah.
Nowhere you mentioned about cost. Do you think the cost will be an implicating factor?
Yes.
Why? Why cost is a factor in glaucoma management?
Yes, so because frequent administration cycles are required. But here...
Lifelong therapy.
Yeah.
Okay, so
Yes,
it is
sir.
very important. Cost is always a very important factor in glaucoma therapy.
Yes,
Always mention that.
Yes, sir. Okay. Thank you, sir.
Now I would like to call next speaker,
Thank you, sir.
Dr. Pankhuri Verma. She is JR from AIMS Patna.
Good afternoon, everyone. I am going to present an unusual occurrence of angle closure glaucoma with retinitis pigmentosa. There is no conflicts or any financial interest to disclose. Prevalence of primary open glaucoma with retinitis pigmentosa ranges from 2 to 12%. Prevalence of PACG in RP patients over 40 years of age is found to be 1.03%. Intraocular pressure elevation due to acute angle closure may aggravate the visual impairment in RP patients with pre-existing optic nerve dysfunction. Angle closure related IOP elevation can be prevented by timely intervention in these susceptible eyes. I'll presenting a case of 34 years old female who presented with complaints of diminution of vision in both eye, more in right compared to left, which was insidious in onset, gradually progressive, with symptoms aggravating in dim light or at night. It was associated with headache from last 2 days, severe in nature and not decreasing even after taking oral medication and not associated with any diurnal variation. So the presenting visual acuity of the patient in right eye was 1/60 and in left eye it was 6/9, improving to 3/60 in right eye. The pressure measured at 10:30 am came to 38 mm of mercury in right eye and in left eye it was 36 mm of mercury. The cornea was clear in both eyes. Anterior chamber was shallow with von Herrick grading of 1. There was no AC pigments or cells found. On gonioscopy we can see Schwall baseline with in 2 quadrants and anterior trabecular meshwork in 2 quadrants with blotchy pigmentation in both the eyes. The pupil were mid-dilated and it was sluggishly reactive. Posterior subcapsular cataract can be seen in both eyes, and on fundus examination, waxy pale disc with temporal crescent, vertically dysmorphic disc along with FA was dull and severe arterial attenuation with bony spicules was seen all around in the periphery. This is the gonioscopic image showing in right eye till Schwall baseline and ATM with blotchy pigmentation, similarly in the left eye. The OCT RNFL of right eye shows RNFL thickness is outside normal limit except in the superonasal quadrant. In left eye it was outside normal limit in nasal and temporal quadrant. HFA theta threshold 24-2 of left eye shows the visual field is reliable and total deviation plot showing severely depressed fields. Glaucoma hemifield tests were within abnormal limits. In right eye, as the vision was less, we couldn't do HFA. The ASOCT shows the shallow angles. So the patient was managed by left eye YAG PI was done and the vision in left eye came to 6.9 and NCT in left eye was measured at 11 as 11 mm of mercury. In right eye YAG PI was done temporarily under mannitol cover as the pressure was very high. After post PI, the pressure remained to be in higher side, that is 40 mm of mercury. YAG PI was done nasally also under mannitol cover, but the pressure remained to be on the higher side. Then phacoemulsification with PCIOL plus TRAP plus MMC was planned under LA for this patient. On post-op day 1, the vision was in right eye was 3/60 and pressure was measured at as 13 mm of mercury. On examination, the cornea was clear, PCL was in situ, bleb was formed and surgical PI was patent. Coming to the discussion part, previous theories regarding glaucoma in RP suggest that migration of pigments is a characteristic feature of retinitis pigmentosa and these pigments in the angle of the anterior chamber has been stressed as a possible etiological factor in glaucoma. Ultrastructure of the lens in RP is altered, causing lens fiber disorganization, which may contribute to the instability of the lens with anterior displacement and narrowing of angle. Recently, zonular stability is speculated to be the cause behind angle closure in RP patient. In a study by Zong et al. Exploration using whole exome sequencing discovered that 5 genes, CRB1, COL2A1, RHO, RP1L1 and PAC6 were responsible for the genetic association between early onset PSEG and RP. The predisposing factors for ACG in RP involve nanophthalmos, cataract, lens subluxation, increased lens thickness, anterior segment dysgenesis and short axial length. Current therapeutic strategies for PSEG comprise laser, medication, and surgery. The take-home message is tubular visual field might be observed in the patients of RP or PSEG at the late stage. Therefore, atypical glaucomatous optic disc, similar visual field defects, and the incidence of rarity may lead to a higher misdiagnosis rate. Hence, comprehensive ophthalmic examination including gonioscopy, full-field ERG, macular OCT, and genetic testing should be done in younger RP patients in for clinical diagnosis. Early intervention and maintenance of target pressure can thus help in maintaining the vision. Thank you.
Okay, it is a well documentation of retinitis pigmentosa with angle closure glaucoma. Any comment, Rajesh, please?
Well presented and documented, I will say. And another part is one view is do you feel PSCG and PSCD, there is a difference. So which one is more in our population, PSCD, the primary angle closure disease or retinitis pigmentosa?
Sir, mostly we see the patient of PSCD, I think that is more common. RP patients are not very well diagnosed, like later on they present, so it is difficult to diagnose and they are not very updated about night blindness or decrease in the vision at the night, so they present late.
Yes, and the other factor was you say ki the migration of the retinal pigment cells, pigments is the cause of, maybe the cause of PSCD, PSCG.
Sorry, open angle, so that was, pigments will go and block the...
In open angle glaucoma?
Yeah.
Not here?
No, sir. Angle closure was found for subluxation and zonular fibers instability are the causes.
Okay. Okay.
So you must have gone into the literature and seen the association of the two?
Yes, sir.
How uncommon was that?
So it is only, like open angle glaucoma is associated.
No, angle closure.
Angle closure is only 1.02%.
Along with RP?
Yes, sir. It has been documented very less.
And then tell me this, while clinically diagnosing a patient which you suspect should have a PSEG and RP, what difficulty will you get while doing the clinical evaluation?
As the disc is waxy and pale, so we are very difficult to diagnose. Thank you, sir.
Now, I would like to call next speaker, Dr. Shweta Bharti. Dr. Shweta Bharti. Okay.
Good morning, everyone. I am going to present a comparative study of association of lipid profile with diabetic retinopathy. There are no financial interest. Diabetes mellitus is a growing epidemic projected to show approximately 783 million, which is 1 in 8 adults who will be living with diabetes by 2045. The 10 years after diagnosis of type 2 diabetes mellitus, 67% of the patients have retinopathy and 10% of those have PDR. Elevated lipid levels are associated with endothelial dysfunction, which leads to blood-retinal barrier breakdown. They have a role to play in hard exudates and therefore risk of vision loss. Aims of the objectives of the study were to study the relationship between diabetic retinopathy and serum lipid levels and to evaluate the relationship between serum lipid levels and the severity of diabetic retinopathy, best corrected visual acuity in patients with DR. It was an observational study which was conducted in Department of Ophthalmology in JLN MCH, Bhagalpur, between April 2023 and April 24. In this study, there were 300 people who were enrolled and they were divided in 3 groups. First was diabetic patient with diabetic retinopathy. second was diabetic patient without any retinopathy, and third was there were no people as a control group, non-diabetic, no retinopathy. Inclusion criteria include type 2 diabetic patients, established cases with more than 40 years of age, and duration of disease was more than 5 years. In exclusion, the patients who had significant hazy media which impaired the examination of the fundus, patients who were already in hyperlipidemic drugs, and with pupillary abnormalities which prevented the adequate dilatation of the pupil, hence difficulty in fundus visualization. Patients who have been treated earlier with laser or intravitreal anti-VEGF injections are also excluded. In the results, there was very clear indication that total cholesterol, triglyceride were higher and LDL were higher in group 1, whereas HDL was higher in the control group. Here also cholesterol, triglyceride were associated with even more severe with PDR, and HDL was low in these. With association with clinically significant macular edema also, total triglycerides were higher, triglycerides was higher, and HDL was here in this unconventionally, it was higher with CSME and it was lower in without CSME. Visual acuity, as we can see, maximum patient in group 2 and group 3 had 6/6 vision, whereas in group 1, the maximum was between 618 and 636, and followed by 69 to 612 vision. Statistically significant correlation between diabetic retinopathy and raised total cholesterol level has been established. The mean total cholesterol was higher in group 1 as compared to group 2 and 3, and the mean triglyceride levels were also higher in group 1 as compared to 2 and 3. In conclusion, I would like to say that further studies are required to establish the causal relationship between dyslipidemia and diabetic retinopathy. It is established, these data can lead to additional support to the current treatment guidelines recommending aggressive lowering of elevated lipids among the diabetic patients. These are the references. Thank you.
Judges, any comment or question, please?
Were this this tests were correlated with the blood sugar also?
Yes, sir.
Blood sugar levels?
Yes, sir.
And what was the correlation between the lipid levels and the blood sugar levels?
So, in type 1 diabetes, here we have taken type 2 diabetes patient, but it is even with strict control of sugar, the dyslipidemia did not go away. We found dyslipidemia even with strict controls of glycemia.
You observed one finding, which was the high density cholesterol
Ji, sir.
was higher in with the presence of diabetic retinopathy, correct?
No, sir. It was in the control group. It was higher. It was lower in diabetic retinopathy.
Retinopathy. So any region, what you find and how you discussed, how will you, anything which you have discussed, why it has happened?
Sir, HDL is protective, which is we have no reason to believe that in control group it will get affected. But in case of our patients, because of diabetes, their dyslipidemia, along with elevation of the bad cholesterol, good cholesterol also decreases. So hence.
But you say that it's with the CSME.
Ji, sir.
CSME, LDL, HDL was lower, you are saying.
Yes, sir.
It was your observation.
Ji.
But it's it should be on a higher side, on a conventional note, basically. That's why you told it unconventional.
Ji, sir.
So any region, it's just a finding, or in
It was-
literature you have searched for?
It was just an incidental finding. That's when the results
So what
have been
literature
clear.
says?
So it says the opposite.
Shweta,
Ji, sir.
very nice, very composed presentation.
Sir.
Well done. There are so many such studies which have been already done. What your study, any new thing which you got? I mean, why did you take up this study? Because there are so many, these studies are already there. Anything which you could get, anything new? Why did you do this study?
So the already existing data is quite controversial. Even in my study, HDL controversy still persists. That is why,
So you
sir.
wanted to add some more controversy to it.
Maybe some clarity.
Very good presentation. Okay.
Thank you so much, sir.
Now I would like to call next speaker Dr. Basudev. Dr. Basudev. Okay.
Good evening, everyone. I am going to present my case on isolated bitemporal hemianopia due to traumatic chiasmal syndrome. So I have no financial interest. Case report is of a 30-year-old male patient who presented to OPD of eye department PMCH with complaint of diminution of vision, right eye more than left eye since 1 month, sudden in onset and progressive in nature. Ali's history of road traffic accident 1 month ago was given that caused head injury to the patient. At the time of RTA, history of loss of consciousness, vomiting and ENT bleed was present. No history of seizure was given, no history of intake of toxin or long-term medication was given. So on examination, general physical examination was normal, systemic examination, CNS and CVS were normal. So we come to the ocular examination. Visual acuity, right eye was 618 with pinhole 612 and left eye was 636 with pinhole no improvement. Pupil was central, round and sluggish, reactive to light, both eyes. IOP was normal, 20 and 19 mm. Eyelid adnexa, right eye showed anophthalmos and hypoglobus and left eye was within normal limit. Conjunctiva was normal, cornea had exposure keratitis, anterior chamber was formed and quiet, lens was normal, EOM was normal in all gazes, and fundus showed disc pallor. And color vision was normal, visual field confrontation showed temporal visual field loss was suspected. So this is the image of patient when he presented to us for the first time, and this is the anterior segment slit lamp image of right eye followed by left eye. So because of trauma history and visual field confrontation test, we ordered a battery of investigation including brain imaging and perimetry. So investigation reports came, NCCT brain showed comminuted displaced fracture of right frontal bone, anterior lateral medial wall of right maxillary antrum, roof medial lateral and inferior wall of orbit, multiple bleed density foci noted in right frontal lobe along with surrounding hypodensity suggestive of contusion with edema causing effacement of ipsilateral cortical sulci. CE MRI brain angiography showed encephalomalacia and age inappropriate involutional brain changes and right frontal contusion was seen. So MRI orbit showed kinking and downward displacement of right optic nerve and encephalomalacia with fracture of orbital wall. So 3D CT face showed features suggestive of fracture, contusion in right frontal lobe with mass effect and edema, subarachnoid hemorrhage and subdural hemorrhage was noted. After that we did perimetry, and perimetry showed bitemporal hemianopia. This is the first perimetry which we did after a patient came to the OPD. So this is the right eye and this is the left eye. So the vertical meridian is being respected, and after that, based on these, the provisional diagnosis is isolated bitemporal hemianopia due to traumatic chiasmal syndrome. And the differential diagnosis for that can be pituitary adenoma, craniopharyngioma, meningioma, internal carotid supracellular aneurysm, demyelination or toxin. So patient was managed conservatively, and on follow-up vision improved, but pupil was still sluggish and fundus showed disc pallor. Repeat perimetry showed no significant changes. OCT RNFL showed nerve fiber loss. This is the fundus photograph on follow-up. It showed disc pallor. This is the perimetry which showed bitemporal hemianopia, and this is the OCT which showed RNFL loss. So the discussion is that traumatic chiasmal syndrome is one of the rare etiologies of chiasmal syndrome caused by optic chiasm injury following head trauma. Main visual field defect is bitemporal hemianopia. Most cases are caused by mechanical stress. However, in this case, radiological finding excluded macroscopic disruption of chiasma, raising the possibility of contusion necrosis associated with functional impairment of optic chiasma. Thank you.
Judges, any comment and question, please?
What imagings were done in these cases?
Sir, brain imaging was done, and because there was hypoglobus and anophthalmos, so face imaging was done. It showed fracture of the orbit. Brain imaging showed encephalomalacia, bleed was there, and optic nerve damage was shown in MRI. Then we did perimetries.
Really well presented and well concise documentation. I think it definitely this bitemporal hemianopia, especially in a young and with a history of trauma, suspects towards that one, and it should be looked for. Otherwise, I have also one case, just wanted to share here, that it was diagnosed as a glaucoma, and that patient was around 34 years of age. He was on anti-glaucoma for last 4-5 years, and his pituitary at that time that it was a pituitary adenoma. It has grown from 1 mm to 6 centimeters. So that's also comes. So it should be investigated and evaluated like your case.
Quite a number of pituitary adenomas are diagnosed in the ophthalmologist's office.
It does. So
They never hesitate to do some investigation if it is required.
Vasudev,
Yes.
whenever you present field, no, for bitemporal hemianopia, you should have right and left adjacent to each other, so as that gives a very instant understanding. Even that you can do, yes. Otherwise, your presentation was very good. And to all the presenter, whenever you pick a topic, you always must think what this study is going to add on the already existing scientific knowledge. Whatever topic you choose, you must think that by this presentation, what am I going to add into the already existing scientific knowledge? Very well done.
Now I would like to call next speaker Dr. Zakia Nujhat. दूसरा डॉक्टर जाकिया
का presentation दूसरा है, topic उसका है study of relationship between albumin. He's doing it from there. You can identify your presentation.
Yes, ma'am, it's not there in the panel.
आपके पास है वहाँ पे? Have you loaded your presentation?
Yes, ma'am.
Just go and check the email. Must have identified it over.
Meantime, I would like to call Dr.
Infection during pregnancy. There was no any past significant history, no any significant family history. On general examination, patient was conscious, average build, and well oriented to time, place, and person. There was no any personal history of tobacco and drug abuse. On ocular examination, for the right and left eye, visual acuity for the right eye was 1/60 partial, and for the left eye, it was finger count close to face. Best corrected vision for the right eye was 6/18, and for the left eye, it was finger count close to face. Lid and adnexa were normal for both the eye, conjunctiva were normal for both the eye, cornea, right eye was clear, in the left eye, microcornea was there, and it was clear. Anterior chamber, right eye formed and regular. For the left eye, it was shallow. Pupil for the right eye was central round reactive, and the left eye leukocoria was observed, and horizontal nystagmus was present. For acceptance of the glass for the right eye was -7 diopter spherical, -1 diopter cylindrical, and for the left eye, it was plain. On ocular examination in the left eye, leukocoria was examined or present, and microcornea was measured by the use of a caliper, wide to wide diameter about 8 mm in size. In the fundus photo for the left eye, there was a presence of a fibrovascular stalk. For the right eye, it was normal. In investigation, B scan ultrasonography, there was a presence of a retinal fold which was causing traction on the retina. CT scan investigation shows the presence of the persistent fibrovascular tissue, and it is basically used to differentiate between the retinoblastoma and PHPV. Now the provisional diagnosis on the basis of the clinical findings and the investigations present over here, it was suggestive of a posterior PFV. The posterior subtype have been defined by the stalk of tissue extending from the optic nerve to the retrolental area, causing an elevation on the vitreous membrane from the optic nerve, leading to retinal detachment, dysplasia, and varying degree of optic nerve dysplasia. Differential diagnosis for these were retinoblastoma, congenital cataract, Coats disease, astrocytic hematoma, and ROP. Coming to the management part for this case, the most important thing for this is the presentation of the patient. The early detected and diagnosed within the few months of the life is the better the visual prognosis for this. And the most important factor for this successful visual rehabilitation is the involvement of the posterior pole. So as and the prognosis for the anterior PFV is more better than those for the posterior PFV. So treatment must address the both component, that is vision and the media opacity and retinal detachment. Media opacities can be removed by lens removal, refraction and amblyopia therapy. Treatment basically here we were not having the facility for vitreoretinal surgeon opinion, so we referred him for the higher center. Discussion, the persistent fetal vasculature, we know that is the failure of the regression of the component of the fetal vessels within the eye. So the fetal vasculature develops to nourish the developing lens prior to the production of the aqueous humor. In normal development, it regresses without any complications, but in most 3% cases, it leads to the spectrum or this outcome of disease. So the take-home message for this is that the early detection and intervention can lead to the salvage of the visual outcome. These persistent visual vasculature can lead to various complications like secondary angle closure glaucoma, cataracts, intraocular hemorrhages, retinal detachments, phthisis bulbi. So the progression during the child lifetime and eye growth can result in the tractional intraocular changes past infancy and affect the children may go to develop the complications. Hence, the parent should be conscious during the childhood, and leukocoria is a very important factor for the early detection. Thank you.
Nice presentation, judges. You can ask any question or comment.
To rule out retinoblastoma, we should do CT scan. Is it that so? Should we do a CT scan in cases of retinoblastoma, or rather it is contraindicated?
Sir, age of the patient was about 20 years, so we gave him the investigation for CT scan. But in infancy and childhood, MRI is mostly suggested.
So shouldn't we do the CT scan in cases of retinoblastoma?
Sir, to rule out the calcifications present in the mask area.
Calcification can very easily be diagnosed by the ultrasound. So it is a very simple test. The only reason we don't do CT scan in retinoblastoma is that there can be a hereditary or the germline mutation may be there, and which will lead to secondary malignancies. And so we avoid the radiations in those cases. It is always advisable not to do CT scan in a case of retinoblastoma. Always go for MRI if required.
So, Dr. Johra, can you tell me what's retrolental fibroplasia?
Sir, the tunica vasculosa lentis persistence behind the lens leads to the fibrovascular tissue hyperdensity, which is seen in the ultrasound and CT scan.
So, had any relations with this PHV, PFB cases?
Sir, anterior and posterior can be differentiated on the basis of that. Retrolental area, mostly anterior is there. Anterior PHV is mostly retrolental area persistence, fibrovascular stroke.
Okay.
Thank you, sir.
I would like to call, are you ready for your presentation? Okay, come. Dr. Jakia.
Good afternoon, everyone. Today the topic of my presentation is study of relationship between albuminuria and fundus findings of type 2 diabetes mellitus patients. No financial interest, disclosure. Diabetes is one of the largest global health emergencies of 21st century. World has around 422 million people with diabetes. The most common microvascular complications of diabetes are diabetic retinopathy and diabetic nephropathy. The retinopathy accounts for 4.8% of 37 million cases of blindness in world. There are multiple risk factors like duration of disease, age of the patient, high blood pressure, pregnancy, blood glucose control, and nephropathy have been studied to be associated with development and progression of diabetic microangiopathy. The objective of this study is to study the relationship between diabetic retinopathy and quantitative albuminuria, and to correlate the urinary albumin excretion with the severity and grade of diabetic retinopathy. Method. This was a one-year cross-sectional study conducted in the Department of Ophthalmology, JLMCH, Bhagalpur, between April 2023 to May 2024. The study comprised a total of 250 patients with type 2 diabetes mellitus. Detailed evaluation of ocular and medical history was taken. An elaborate biomicroscopic examination of anterior segment was performed. Ophthalmoscopic and biomicroscopic examination of ocular fundus was done. And grading of the severity of retinopathy was done according to the ETDRS classification. Blood samples were collected from the anterior cubital vein for blood glucose level. Serum creatinine level was assessed by fully automated analyzer. Urine albumin levels were estimated by random spot urine collection method, and the patients were then divided into 3 groups depending on their urine albumin excretion. Normoalbuminuria, that is urine albumin is less than 30 microgram per milligram of creatinine. Microalbuminuria 30 to 299, and macroalbuminuria more than 300. These groups were then compared with each grade of diabetic retinopathy, and association between the 2 groups were determined statistically. In the inclusion criteria, we included type 2 diabetes mellitus cases, either the established cases or recently diagnosed cases, and patient with age of more than 40 years. And among the exclusion criteria, significant media opacities precluding fundus examination, patients who've been treated earlier with either laser or intravitreal anti-VEGF injections, patient with pre-existing renal disease, for example, renal failure or obstructive uropathy, and patients with serum creatinine of more than 2 mg per dl. In the result, all the patients were between 40 and 85 years of age, and out of 250 patients, around 54% patients were male and 45% patients were female. And in this, around 66% patients were having diabetes for less than 5 years, and around 3.6% patients had diabetes for more than 15 years. And among the total 250 patients, around 72% patients had no retinopathy, and 8% patients had mild NPDR, 9.6% patients had moderate NPDR, around 1.6% patients had NPDR, and around 3.2% patients had severe NPDR, and 5.6% patients had proliferative diabetic retinopathy. And this is the graph showing the distribution of severity. In the no retinopathy group, which constitute about 180 patients, there were 61% patients who had normoalbuminuria and 69 patients had microalbuminuria. In the mild NPDR group, almost 30% patient had normal albumin excretion, normal albuminuria, and 70% had microalbuminuria. And in the moderate NPDR group, 8.3% had normoalbuminuria, whereas 91% had microalbuminuria. And in the severe NPDR group, the ratio was 50-50, like 50% patient had microalbuminuria and 50% had macroalbuminuria. And in very severe group, 62% patient had microalbuminuria and 37.5% patient had microalbuminuria. And in the PDR group, 21% patient had microalbuminuria, whereas 78% patient had macroalbuminuria. Next question. The result between grade of diabetic retinopathy and duration since diagnosis was significant. Retinopathy was seen in all patients who had diabetes for more than 10 years. Majority of the patients with non-proliferative diabetic retinopathy had microalbuminuria. None of the patients in the mild and moderate NPDR group had macroalbuminuria. In severe NPDR group, 1/2 of the cases had microalbuminuria and other half had macroalbuminuria. And most of the patients who had proliferative retinopathy, they have macroalbuminuria, whereas remaining only 21% had microalbuminuria. And a substantial proportion of patients without retinopathy also had microalbuminuria. So in conclusion, despite the high prevalence of type 2 diabetes mellitus patient, the prevalence of diabetic retinopathy is relatively low, 28%, particularly the advanced grade of retinopathy. And this study demonstrated that macroalbuminuria was associated only with those patients who had either severe NPDR, very severe NPDR, or PDR. And none of the grades of diabetic retinopathy had normal level of urine albumin excretion. Microalbuminuria was a finding associated with all grades of retinopathy, with skewing towards the lower grades of diabetic retinopathy. and there's a strong association of urine albumin excretion with proliferative diabetic retinopathy. However, the association between lower grades of diabetic retinopathy and urine albumin estimation is not very well defined. Thank you.
It is very nice presentation. Judges, you can ask any question or comment.
Come to your conclusion page.
They have
Okay,
closed the...
fine. So you, that's okay. So you said in spite of having high prevalence of diabetic retinopathy, the prevalence of diabetic retinopathy is less. No, type 2, in spite of having high type 2 diabetes, the prevalence of, no, bring the last page. It will come. So despite the high prevalence of type 2 diabetes mellitus, the prevalence of diabetic retinopathy is relatively low. So you feel 28% is low.
Sir, when we see the prevalence of type 2 diabetes mellitus patient, that is around 422 million patient, in those cases, sir...
This load is quite high, no? Out of those, almost 1/3, 28%. It's not low, it's very high. If you say that, it will give a wrong impression that it is low. It's quite high actually. And then your classification was done based on ETDRS.
ETDRS classification.
What does it stands for?
Sir, ETDRS classification is early treatment diabetic retinopathy study.
So how you classify, give me the signs of severe NPDR.
Sir, severe NPDR, in severe NPDR, there is a 4-to-1 rule in which it says that if a patient has intraretinal hemorrhages in 4 quadrant, or the patient have 2 quadrant of venous bleeding, or 1 quadrant of, in 1 quadrant if the patient has IRMA, then it is categorized as severe NPDR.
But I do have the things, what other study says, what's the prevalence of diabetic retinopathy in type 2 diabetes mellitus?
Sir, prevalence is almost similar, say, in most of the other studies.
Similar,
also.
what is reported? What we know, it's around 20%.
Okay, sir.
So this albuminuria means there is not some nephropathy is there, है ना?
Yes,
so
ma'am.
which presents earlier, the retinopathy or the nephropathy in diabetes patient?
Sir, usually, sir, micropathy presents earlier than retinopathy, sir, because most of the many of the patients who had not developed diabetic retinopathy, we found in our result the patient had already developed microalbuminuria.
So again, what your study did got some different results, because you have so many such studies. Anything different you got?
Sir, difference, as such there was no difference found, but...
Why did you do this study then? What did you
Sir,
had in your
we
mind?
just wanted to know, so if by seeing the urine albumin excretion, can we start any drug which can prevent diabetic retinopathy development in future or not?
Okay.
Thank you, sir.
Now, thank you. Now I would like to call next speaker, Dr. Sudarshan Yadav. Dr. Sudarshan Yadav. Okay, now I'd like to call Dr. Gaurav Hemram.
Good afternoon all. I am going to present comparative study of surgically induced astigmatism in superior versus superior temporal incision in manual small incision cataract surgery in Department of Ophthalmology, JLNMCH, Bhagalpur. As we know, cataract is a leading cause of vision loss, particularly in developing countries like India. Phacoemulsification is considered the benchmark for cataract surgery in developed nations. However, the burden of cataract and limited resources necessitate an alternative like manual small incision cataract surgery to the phacoemulsification, which can give comparative result. Several factors influence postoperative astigmatism, like the site of incision placement, size, and shape of incision. Aims and objective of study to evaluate and compare degree of surgically induced astigmatism following manual small incision cataract surgery, especially comparing outcomes between superior and superior temporal incisions, and to assess the alterations in the preoperative and postoperative astigmatism, and to investigate the impact of two distinct incision sites on visual acuity after surgery. Material and method. The study was conducted in Department of Ophthalmology, JNMCH, Bhagalpur. Inclusion criteria. Patients aged between 40 and 85 years. Patients with nuclear and cortical cataract ranging from grade 1 to hypermature cataract, as well as posterior subcellular cataract, and patient who provide consent to participate in the study. Exclusion criteria. Patients below 40 and above the 85 years of age, patients with other type of cataract like traumatic cataract and any ocular pathologies affecting the anterior or posterior segments, and patients who do not provide consent to participate in the study. Methods. Total of 200 patients attending the OPD ophthalmology department in JNMCH during 20th March 2023 to 20th February 2024. Patients were randomly assigned to two groups, with each group comprising 100 patients. Group A manual small incision cataract surgery with superior tunnel incision. Group B, a manual small incision cataract surgery with superior temporal tunnel incision. Postoperative examinations. Patients were examined on postoperative day 1, day 3, post-op first week, third week, and sixth week. Examination was focused on surgically induced astigmatism and best corrected visual acuity. Measurement of surgically induced astigmatism was calculated on the postoperative day. Results. All the patients were between 40 and 85 years of age. Here, different age group in the number of patients. Among 200 patients, 51 persons were male and 49 persons were female. Here the comparison between superior incision and superior temporal incision. Here the preoperative visual acuity, superior incision and superior temporal incision. Here the post-op visual acuity in post-op day 1, post-op day 3, week 1, week 3, and 6th week. As the post-op day increases, the visual acuity gets better. Here the post-op visual acuity in superior temporal incision. In superior incision, surgically induced astigmatism were 0.79 diopter plus minus 0.61 diopter, and in superior temporal incision 0.61 diopter plus minus 0.45 diopter. Discussion. The various theories which explains the surgically induced astigmatism. Astigmatism is proportional to cube of the length of incision via Gill and Sanders. Astigmatism is inversely related to the distance from the limbus, Jeffrey, Samuel, Muscat. Incisional funnel, imaginary pair of curved lines diverging outwards from the limbus. Incision made within the funnel will be astigmatic equivalent, Paul Cook. The simple rule to follow is that wherever the incision is made, that area will flatten, and wherever sutures are applied, that area will flatten. In superior temporal incision group, the minimal with the rule astigmatism and early rehabilitation of visual recovery could be due to location of the incision away from the visual axis and steepening of the vertical meridian. Besides, the average astigmatism was in the superior incision group is higher, in majority of them being against the rule type than that of the superior temporal instant group, in which majority of them are having with the rule astigmatism. Conclusion. Postoperative astigmatism being common complication of cataract surgery can be reduced or avoided with modifications of location, size and shape of the self-sealing incision. Placement of incision temporally or superior temporal is one modification to minimize the high pre-existing against the rule astigmatism that occur in the elderly population. It is seen that the superior temporal incision produces with the rule astigmatism in most of the cases postoperatively, along with the capability of neutralizing against the rule astigmatism, which will present in the majority of elderly patients with cataract. Thank you.
Judge, please, any comment and question?
Thank you. It's a good topic, I think very real common topic. And just to say, it was also similar topic was with my thesis. So very relevant. What's a Cox triangle, a Cox funnel? You have already told. What's a Cox funnel?
Cox funnel. This was Hindi.
It was that you have already told. Incisional funnel is Cox funnel, correct? And in conclusion part, when we do a study, we are sticking to your part, whatever you have done. So your study says you have done the comparative study of superior versus superior temporal, correct? But in conclusion, you have written that the temporal incision has less astigmatism. We should shift towards temporal one.
Statistical significance was also, I don't think, mentioned whatever difference in result was there. So it's difficult to draw a conclusion into.
Yes, it should be, the conclusion should be according to the what we have studied.
Statistical analysis that we should.
So that's one part. So it should be taken in account every time. Point number 2. Third, how will you, whatever you have studied, whatever you have concluded, how will you apply in your clinical practice for the benefit of patient?
सर अगेंस्ट द रूल जैसे एल्डरली पेशेंट ज़्यादा रहेगा तो उस पर सर सुपीरियर टेम्पोरल इंसिजन दे सकते हैं.
Point 1.
और सर डीप सॉकेट अगर रहेगा उस पर भी सुपीरियर टेम्पोरल.
Okay. I think it's the message should be clear because superior temporal induces less astigmatism, as you are saying. We can say if there is a higher astigmatism, with the rule, we can go with a superior incision. And if it is of a lesser magnitude, we can select a superior temporal if it is with the rule. In ATR, always temporal incisions are better.
By this, we have finished this session, and I would like to thank all the speaker, chairperson, panelists for conducting this session. And I would like to request all the judges and panelists to come for one group photograph because it was a very long session.
Presenters, please come for a group photograph now so that we can conclude it.
I would really like everyone to clap for these young people. They have put lot of efforts, and we wish you well and keep improving. This is all for your improvement only.
कुछ तो बोलना है भाई. थैंक यू सो मच साइंटिफिक कमेटी की तरफ से सर कि सारे जजेस, पैनलिस्ट, चेयरपर्सन और जितने भी ऑडियंस और स्पेशली प्रेजेंटर 99% सर प्रेजेंटेशन हुआ. और थैंक यू सो मच सर प्रेसिडेंट सर, कारक सर और सेक्रेटरी सदजीत सर की साइंटिफिक कमेटी को इतना सपोर्ट किए. और स्पेशल थैंक्स टू हमारे साइंटिफिक कमेटी मेंबर डॉक्टर अकबर, डॉक्टर भावेश, डॉक्टर अनीता मैडम, डॉक्टर नवीन, डॉक्टर अभिषेक रंजन, डॉक्टर अभिषेक आनंद. किसी कारण से वो लोग नहीं आ पाए और मैं साइंटिफिक कमेटी के तरफ से स्पेशल थैंक्स सत्यजीत सर को और माइक हैंड ओवर कर रहे हैं अपने सेक्रेटरी सर को. और रंजना मैडम के सपोर्ट के बिना कुछ भी नहीं होगा, तो थैंक्स टू रंजना मैम.
Organizing secretary क्या Thank you. Once again, thank you very much to all the postgraduates. Big cheers for all the postgraduates who have participated. Really commendable. You have come from different parts of Bihar, so it's very nice. We would like to thank the hotel management. We would like to thank Pappu Gunjanji for the wonderful arrangements. It's really commendable that so many postgraduates have come from Bhagalpur also. Special thanks to all the presenters, all the panelists, all the moderators, all the arrangements that were made by the hotel throughout the day for breakfast, all the people who were serving food, dinner. Big thanks to all the pharma companies who really supported us, without whom we couldn't have completed this. A big congratulations to everybody on the successful completion of the 18th annual midterm conference. Thank you very much. And we would like to request all of you to please come to Darbhanga, which is on December 15th, 16th and 17th for the annual BOS conference. Thank you very much. Thank you very much. Thank you to audio-visual team for the wonderful thing. You would have noticed that the audio-visual didn't stop at any time because we had a separate generator running. Everything was taken care of, especially that everything runs smoothly. Thank you very much.